a good reason. Thank you. Recording. Okay. Uh, so uh, I'm asked by Jeannie, our staff, our director, to make sure that if you haven't gotten alerts from SBCAN, you should go to sbcan.org and sign up for our regular mailing list. That gives you information about all our activities, but also things that you can do as a citizen to help bring the things we want into the world. So sbcan.org. And our North Counties Roundtable, we don't have the speaker set yet, but that will be February 8th. And we will have another of the South Coast Roundtables later in February. If anyone has ideas what they'd like to see discussed, I would love to hear from you personally. So you can email me, SBCAN, sorry, rflacks at gmail is a good way to get me. I'm thinking that one of the issues I want to discuss in a roundtable is the mysterious question of something called the builder's remedy, which has gotten a good deal of attention in some of the media, and it may be threatening our entire future or not, but something that we need to learn more about, and it isn't easy to understand. So that may be on the agenda next month. Anyway, welcome to everybody, and I think more people may be joining us as we go forward. A lot of people registered for this. And I'll repeat, this is the SBCAN monthly South Coast Roundtable. And I got interested in the question of universal health care when I was 10 years old. And I like to tell this story because I used to tell it to my classes at UCSB when we discussed public policy. When I was born in 1938, the Social Security question had been just passed by Congress. And that was a compromise. The original Social Security plan was to include health care as an integral part of Social Security. And in order to pass the retirement feature of Social Security and other features, FDR decided to separate health care to come back at a later time to get a universal government health care program adopted by Congress. And the reason that it was so contentious was because the American Medical Association was fiercely and highly organized against what they called socialized medicine. So in 1948, the national debate topic for schools was, should we have socialized medicine? And I remember in, I guess, sixth grade, we had a debate, and I was advocating for the class, in front of the class, for socialized medicine. And I had to debate other people on the other side. And that was a year when President Truman campaigned to have socialized medicine or universal health care adopted by the United States. And he was elected partly because he did advocate that, I believe. I can explain that, but I won't. Anyway, that didn't happen because the American Medical Association, among other groups, but probably primarily, fiercely opposed this. 1968, 20 years later, Lyndon Johnson proposed Medicare, which was socialized medicine for people on on Social Security. And the reason it was not universal, but only for the retirees, again, was because of the opposition of the AMA, among other groups. But it was possible to pass it as part of, as Medicare as we know it. And the idea was to bring back universal health care as soon as possible when the time was ready. So you see where I'm going with this. We're on my entire life has been one waiting for universal health care. Obamacare is the closest we've gotten to it. I think we'll hear today why that is not adequate for fixing the healthcare system in this country. I heard on NPR this morning someone say we have the most inefficient healthcare program in the world. We pay more than any other people for our healthcare, and our life expectancy does not equal that of 15 or 20 other countries. That's a good way to summarize it. So the AMA, the Doctors of America, always opposed universal health care. And that's why I was very excited when Dr. David Lebell, an old and very good friend of mine, recently retired from that, he suggested that there's going to be legislation introduced in California for California universal health care, that he and other doctors in this community were in the forefront of advocating for that. So this is a huge political turnaround that prominent, successful doctors want to change the health system in this fundamental way. And so he brought together two of his friends, other doctors in the community. I'd love you to meet David Lebell and Dr. Jerome Hoffman and Dr. Nancy Greep. They will take over now. If you have questions and comments, please put them on the chat. I will be the monitor of chat, and at appropriate time, I will filter your comments or pass them on to the panelists for discussion. I think that works better than trying to just have people speak from the floor, but maybe later we'll have that opportunity as well. So use the chat, use it freely. David and Nancy and Jerome, take it, and everybody put on the speaker function on your menu rather than the gallery function, and you'll see them. They're all together in the same room. You'll see them in a nice large screen if you do that. Where are you? You're not.
Are we there?
Yeah, we're there.
Now you're there. Great.
There we go. Hi. Okay. Thanks, Dick. Thanks for inviting us, and thank you, SBCAN, and thank you, Nancy. Assuming the rest of you can, yeah, there we are. Yes, I'm happy to be here with Dr. Nancy Greep and Jerome Hoffman. They have been really spearheading the single payer process here in Santa Barbara and in California, and I'll let them introduce themselves as they speak. But the operative process here is that we have all been in practice, and we've all seen the sometimes heartbreaking things that happen when patients don't have good access to good timely healthcare. And I think that helps to kind of drive our concern for trying to make our system better. So I think we'll start with Dr. Nancy Greep.
Thank you. So if you could switch the slide. So I'm going to start by just briefly going over what are the problems with our healthcare system. And then Dr. Hoffman, Jerry, will take over later and talk more about social determinants of health and also the single payer system itself. So we have a lot of problems. I always hate to use the word system, because the truth of the matter is we don't have a healthcare system. There's no system that really organizes our healthcare. There's no system that puts resources where they're needed. So we have affluent areas that just keep getting more and more hospitals and providers, and we have areas that don't have healthcare that just become healthcare deserts. So there's nobody overseeing that. It's a very costly system because it's a multi-payer system with private insurers, multiple private insurers, public insurers. It's administratively very complex. And it doesn't cover everybody. We have patients that have no health insurance. And then we have a problem that our patients who are color and poor are not getting good care. So we have poor population outcomes. As was already mentioned, the whole system is driving doctors crazy. It's also driving patients crazy. Doctors are starting to leave practice, and we already have a doctor shortage, so that's a problem. And then the more recent problem is that now we have Wall Street marching into the healthcare scene, and they're creating additional problems for us. So could I have the next slide? So in terms of the lack of a healthcare system, as I mentioned, there's really no control over the resources. We also have an imbalance of primary care physicians and specialty physicians. We have too few primary care physicians that can manage patients' care and provide preventive care, and too many specialists. There's no control of our prices. Things are completely out of control. We have electronic health records, which were created for the purpose of billing, not for patient care, and they don't talk to each other. Then we have a very limited role of public health, which is unfortunate. This is a slide just showing how costly our system is. As you could see, the health expenditures per capita in the United States up there top in green are roughly twice what they are in other comparable developed countries. Next slide, please. So that's on a population basis, and on an individual basis, individuals are having a lot of trouble paying for healthcare. As you can see, this is a slide showing the rise in family premiums over time, up there in the top, and then down below you can see the fact that workers' wages have not kept up with the increase in family premiums. And on top of that, employers are increasingly putting more costs onto their workers in the form of deductibles and copays. So the problem is that as patients cannot afford their care, they're starting to skip their care, or their care is getting delayed, and oftentimes there are serious consequences of that. They're also going into debt. Like 40% of the population now has some kind of medical debt. Healthcare debt is the main reason for bankruptcies these days. It's also becoming the most common cause of foreclosures of houses, because people can't pay for their mortgage because they're burdened with healthcare debts. So let's go to the next slide. So as was already mentioned, in spite of the fact that we spend twice as much on healthcare as other developed countries, our outcomes are poor. Here are just two examples. On the left side, you can see that life expectancy is several years below that of other developed countries. Not only is it below, but it's also more recently declining, which is very concerning. And on the right, you can see just another example of poor outcomes of our maternal mortality, which is much higher than other comparable wealthy countries. Similarly, infant mortality and many other measures of population health are poor in the United States. Next slide, please. So what's the problem? Why is we spending so much money on healthcare? Well, one is that we don't have any control of prices, and so drug companies and insurance companies, they just charge what they can get away with. And the other is because of the complexity due to the multi-payer system of health insurance. It's administratively very complex. If you can imagine, in a doctor's office, they've got to deal with all different kinds of insurance. Every patient's insurance is different, how much their copay is, whether they've met the deductible, So that requires a lot of personnel and money. And then our drug prices are completely out of control. As I mentioned, we have the imbalance of primary and specialty vision. And then more recently, as I mentioned, we now have Wall Street involved, where their main concern is not patient care, but profit. Next slide, please. This is just a slide showing, as we've gone along, the increase in the administrative personnel, which is shown in the blue over time versus the number of physicians. What are all these people doing? Well, they're taking care of seeing whether or not you're eligible for their insurance. There's the whether you are, the insurance company is going to let you have a procedure that your doctor wants, et cetera, et cetera. So all of this requires money to hire all these people that basically get in the way of patients' care. Next slide, please. As an example of this, you can see here that administrative expenses in hospitals in the United States, if you can imagine, 25% of hospital revenue is actually spent on billing. And to illustrate this, you can see Duke Medical Center, which has 957 beds, it has 1,600 billing clerks. Contrast that with Toronto, which is in Canada, where they have a single payer system, a larger number of beds in the hospital, they have 7 billing clerks. And most of what those billing clerks are doing is managing bills from United States citizens who come across the border and need health care. Next slide, please. Drug prices. You can see again that in the United States, we spend more on drugs than anywhere else in the developed world. In fact, we seem to be paying for the rest of the world's drugs. I was just shocked to read the other day that it cost Pfizer $13 to make Paxlovid to treat COVID. And we had no cost of that drug during the pandemic. But then once the pandemic was declared over, now the Pfizer comes in and it's going to charge $1,400 for a 5-day course of medication. Unbelievable. And I read also recently that Bernie Sanders, of course, is a great champion of healthcare. In his health committee, he recently investigated the cost of inhalers in the United States. You can see that Teva was charging $286 in the US. The same thing sold in Germany for $9. It's crazy. Next slide, please. And then we have the problem of uninsurance and underinsurance. You can see on the left-hand side of the pie chart, a little more than half of people seem to be insured all year long, and their insurance is adequate. But on the right-hand side, you can see that we have a certain percent of people who are frankly uninsured. But then so many people who have insurance because of their high deductibles and copays, in spite of the fact that they have insurance, they still can't afford to pay for their health care. So they're underinsured. As a result, 43% of people in the United States are basically either uninsured or underinsured. And as we've already mentioned, the serious consequences of not having adequate insurance. So with that, I'll stop and let Jerry take over.
Hi, everybody. Jerome Hoffman. Thank you for having me. I'm hoping to spend the next few minutes talking about broader issues or the way in which our failed so-called healthcare system interacts with so many social problems that, as I understand it, SBCAN is interested in trying to help and fix, etc. As Nancy said, it's not really a system, but I think to be precise, we should recognize it for what it is, actually is, and that's a marketplace. It's not a system, it's a marketplace. Maybe Nancy, you can get rid of the slide for a minute.
Yeah, sure.
So, and that reminds me to say what I think is really important and touches a little bit on what Nancy has already said, and this is only going to get worse as corporate medicine takes over, and that is the notion that health care can have one of two goals. It can be about health or it can be about profit. It's quite clear that it cannot be about both. And right now our healthcare system is entirely about profit and almost nothing about health. That is not to say that your interaction with your doctor is never about health, or that there aren't individuals who are interested in providing health as an outcome for healthcare, but the system itself, the overall management is all designed to maximize profit. And when health and profit conflict with each other, we know which one loses. I wanted to make a couple of brief comments about some of the things that Nancy said. She pointed out that there are a lot of ways in which our outcomes are poor. I'm sure some of you know that there's a thing called the Health Olympics, and there are various ways in which people measure health outcomes. In the latest World Health Organization Health Olympics, the United States came in 37th in the world in terms of best outcomes, just below Slovenia, I believe. We're just about the lowest of all the rich countries. And on the life expectancy slide, you saw that we're only a few years different, 5, 6, 7 years different than Japan, which is at the top. But don't be fooled that that's a small difference. If we were to remove all deaths from heart disease and cancer, we would still be just below Japan in terms of our life expectancy. And heart disease and cancer are our 2 leading causes of death. Let me go back to this larger question of why is it that we have such bad healthcare outcomes, and I'll try to address this in terms of larger social issues as well. So there are medical reasons. Let me first say it's not because we have such terribly bad healthcare in the United States, or the potential for bad healthcare in the United States. Technically, we have excellence. I've gotten to do sabbaticals in 4 different countries around the world during my career at UCLA, and I got to watch the way healthcare is done on the ground in the moment in different places. And I'm pretty sure that the healthcare, that the technical proficiency that we have in the US is at least as good as anywhere else. And at its top end, it's very, very good. And people around the world in other advanced countries look to the US for research and ideas and the latest, et cetera. So it's not that we're not capable of giving good care. But there are 2 big medical issues. One is undertreatment that Nancy's already mentioned, that really relates to people not going to see the doctor, going too late, not being able to pay for their medicines, et cetera. The other that I think needs mention, that I spent a lot of time in my career talking about, is overtreatment. It turns out that we not only have bad health outcomes for the poor, which is certainly a big, big, big problem in the US, but if you look at rich people in the US compared to rich people in comparative countries, we are richer. Our rich are richer than the rich elsewhere as an average. But their health outcomes are also much worse than the rich people in other countries. And that's because we have this other problem of overtreatment. And I'm not going to spend more time on it. We could spend a lot of time on it, but we decide on what you get based on your medical insurance coverage, which means if you're poor, you tend to get less. But if you have means, you tend to get more than you need. And that turns out to be quite harmful. Those are sort of medical things, but if you look at the next slide, Nancy, this looks at the social determinants of health, and I'm sure all of you know what the social determinants of health are. There are things like housing or lack of housing, food deserts, next one, problems with proper diet, racism, drug use, trauma, etc. And this slide suggests that the contribution to premature death is much less related to what kind of healthcare you get than it is to other factors. And those factors, here it says social circumstance 15%, behavioral pattern 40%. Those are actually 2, they should go together, and environmental exposure as well. The social causes of bad health outcomes are probably at least half, if not significantly more, of the contribution to death, and it's probably even more for other health outcomes. The other thing that goes into this, besides just the social determinants, and you all know that in our country, we have large groups that are subject to the privations related to these social determinants. But if you go to the next slide, the other thing is inequality. And some of you, I'm sure many of you know, that inequality in the US is substantially more than in other countries. I love this slide because it's very visual. And what you can see is that there's a line showing the relationship between income inequality and health and social problems. This is just one way of measuring it. There are many, many similar slides that use different metrics to come up with the same answer. And you'll notice that Japan is way down on the left. It has very good health outcomes and very little income inequality. And by the way, this slide could be repeated not just for income inequality, but also for wealth inequality. As you go up the slide, you'll see other countries are more unequal, and everyone that's more unequal has a little bit worse outcome. And then you go way to the top, almost off the screen, is the US, which has by far the worst outcomes and by far the worst income inequality. And by the way, there's a wonderful book called The Spirit Level by Wilkerson and Pickett, which some of you might want to read, which shows this concept in far more detail. And it also points out that the same slides could be made not for the US versus other countries, but for states within the United States, where the states with the greatest income and wealth inequality have by far the worst outcomes. Those with the least inequality have the best outcomes. The last thing I want to say before opening this up to the audience is to make a comment about who gets hurt. So we already talked about patients get hurt, particularly poor patients, but all of us really. And it's not just in bad health outcomes, but all the worry that's associated and all the social stresses that occur with this. But communities as well. And there are tremendous effects of our terrible healthcare system on communities, particularly communities of color and poor. But I wanted to mention one last thing, which is providers as well. And I'm going to talk mostly about physicians. Nancy mentioned the word burnout. I like to think of this much more in terms of moral injury. Moral injury is the sense that you became a physician because you wanted to do good. I read a lot of med school applications in my career, and every one of them said, why do you want to be a doctor? I want to help people. I'm not sure 20 years later, all doctors are in it for that reason, but I think most people who are applying to medical school really want to do something good. And they, unfortunately, they get disabused of the possibility of doing that in many ways in our healthcare environment. And so they start to change. It's very hard to be a physician who thinks I'm here to try to take care of people and help the society and help our communities with regard to health, and actually know that my function every day is to be a cipher for a profit-making industry. The current electronic medical records are enormous, and they provide enormous amounts of information. Almost none of it has to do with health. In fact, if you try as a physician to look at EHR to find out some health information, it's very hard. You often miss it because it's so inundated with questions with details that are related to how are we going to bill this patient. So if you're the physician and you're sitting there and you can't look at the patient, or you could, but you don't because you're spending so much time on the computer, and mostly what you're doing with the computer is following guidelines that have nothing to do with health and often have to do with maximizing profit, and filling out a computer that has nothing to do with health but has to do with maximizing profit, it's very hard to stay committed to this profession, which is in some ways no longer a profession. So I'm going to end there. Thank you guys for having us. We would love to hear your comments, not just your questions, but your experiences with the healthcare system. I'll put this back to Dick Flacks, and he can moderate how we get that. And before we do that, David was going to ask us a couple of questions to get the discussion going a little bit further.
Yeah, thank you. On that last topic of physician burnout, one of the things that I've identified and felt is as physicians are asked to do more with less, that becomes more challenging and frustrating and hard. And when we're asking for more staff or more space, and we're just told, well, we can't afford it, when the reality is, as things are driven more by profit, we are told more and more to do more with less. And then just to tie it in, this Sutter takeover of Sansom is more along that same line of a more profit-driven healthcare process.
And I was just gonna suggest that the other thing that physicians ask for, or want, or need, that you didn't mention, but which I'm sure you know, is time. Time to spend with your patients, and instead we get this Lucy and Lucille Ball
The chocolate.
yeah, the factory line, assembly line to see patients quickly, and you're spending all that time with the computer. That's outrageous.
So I think the big question is, I think you guys have really outlined how pervasive the problem is, and I'm sure that everyone has experienced some degree of issues, but how can single payer help solve this?
Well, first of all, the system is so complex right now and so expensive that a single payer would eliminate all the many of the administrative expenses associated with our private health insurance system. And the money saved from that could be used to enhance healthcare for everybody. So that would certainly help. That's
Yeah,
what-
it'll be used for other social needs as well. There are communities that are devastated by our system, by the way it makes people bankrupt. If you think of all those social determinants, our non-system, I think, contributes to almost all of them. Housing problems, to problems with paying for food, getting basic needs, with anxiety, so tremendous anxiety. I was in England on sabbatical at the time that my in-laws, who live in England, who are poor working class people, not poor, but lower middle class working class people, retired, were living basically on a pension. And I spent a year there, and during that year they both needed multiple hospitalizations. And what was really striking to me as I was there was that while they worried about the medical problems that they had and their medical needs, they never once, never in any way were worried about how are they going to pay for this, what was going to happen to their house, any of those things. All of those, that's just a tremendous cause of insecurity here in our country. But I want to say that this is not fixing single payer, won't fix everything. We have to get profit out of medicine, out of healthcare, if we really want to fix it. And even that is only part of the many related social problems that we have. So this won't fix everything, but it certainly would go a long way towards a lot of the problems that we've been talking about.
Could you advance the slide to the one about how it will help solve our problems? For example, one of the problems that we mentioned is that not everybody has not everybody has insurance, and not everybody has adequate health insurance. With a single payer system, everybody has, keep going. It's not that one.
Yeah,
Here,
that was it. The one
Okay.
you were on.
There.
Yep.
Yeah. So this, I think, summarizes this, is it that with a single payer system, now we would actually have a system where we could prioritize putting our resources where they were most needed. It would control costs, some by eliminating the administrative expenses, but also directly by controlling costs. Administratively, it would be much, much simpler. We imagine that patients would be given a smart card, as they are in France and other advanced countries with universal systems. And they go to the doctor's office, that put the little card in, and that brings up their health history. And that way, doctors' offices and different offices can communicate better with each other. And then because resources could be put towards areas where they're currently not being expended, this would help to alleviate the inequities that we have in our healthcare system. And certainly, if doctors didn't have to deal with all these crazy health insurances, the burnout would be a lot less expensive, a lot less worse. In terms of corporate takeover, a single payer system, I think this is going to be one of the most difficult problems about advancing to single payer system. Yes, we would like to eliminate the for-profit businesses that are in our healthcare system. This is going to be difficult to accomplish. But ideally, we would set it up so that institutions could not be for-profit. By that, I mean for-profit where they're state shareholders that you have to pay attention to. So that would be eliminated.
I think a lot of, we have to acknowledge that a lot of the devil's in the details, and people mean different things by single payer. So we have to be a little bit careful. There are multiple different sort of single payer systems around the world, all of which do better with better outcomes and cost less than ours. So the notion that where are you going to pay for it, it's going to be so expensive is obviously a little bit ridiculous. But there are differences within those systems, and I think to get an ideal system, we need to put public health in there. We need prominent roles so that community health becomes important. We would ideally pay doctors a salary rather than allowing them either to be capitated so that they are incentivized to do less, or to be fee for service so they're incentivized to do more. We'd also need to make it sure that primary care providers, who turn out to be the most important element of health outcomes, aren't paid 1/5 of what any surgeon might be paid. There are many ways in which this system can be tweaked for the good or for the bad. And let me just say two other things. One is our current notion of not-for-profit. The not-for-profit hospitals in our community, in our society, all function just almost identical to for-profit systems. That's not to say they're as bad as the corporate takeover business will be. That probably is going to make it even worse. But the not-for-profits in most ways act just like a for-profit system. And I forgot what the other point I was.
So you mentioned now a different, the single payer, will help. And I understand that there's a system that's being proposed in California coming up. You guys want to say something about that?
Yes, and before, I'm going to let Nancy say that, but before I forget, I wanted to make the second point, which is that people are calling Medicare Advantage in some ways a single payer system. They're calling it Medicare. And there's a tremendous push to privatize Medicare. Originally, it was designed by George Bush W. to give people money so that they could buy insurance. But another way of privatizing it is have it all go through the feds, but it goes then to insurance companies, which then function just like a multi-payer system, just like our current system. And there's a tremendous push now to make all of us, every senior, become part of a Medicare, so-called Advantage system. There are advantages of MA, but there are massive disadvantages once you get sick. So we have to be really careful about how we think about what a single payer system is, how we decide what is appropriate healthcare, what is inappropriate, what's too much, what's too little. And those are difficult questions, but we have to have some mechanism to do that so we're not just the Wild West.
Well, we would like to ideally have healthcare providers in charge of those decisions and not bureaucrats in an insurance office.
So,
Yes, there is, it's very exciting. The California Nursing Association is going to be introducing a bill in probably the first week in February called CalCare. It is a single payer bill, and we're very excited and hoping that can go through the legislature. Where, if anybody on this call is interested in seeing single payer come to fruition, there's going to be opportunities to work on seeing if this gets passed by making visits to our local legislature. We've already been to see Greg Hart. He needs some additional education on how this system would be helpful.
yeah, let me just make a political comment. I don't think legislators are leaders. I think they're followers, and they mostly follow what's going to get them elected. No, that's not true of 100% of them, but it's true of a lot of them. So in most cases, what gets legislators elected and reelected is money. And we don't have a lot of money. And the insurance system and the hospitals and the drug companies have an enormous amount of money. You probably know that Big Pharma is the richest industry in the world, and they spend more on lobbying than any other industry in the world, including oil, and including guns and war machine. I mean, they're a mammoth. And so I don't think we're going to win over enough legislators by convincing them, because they have a different incentive. The only way we'll win them over is if enough of us make it clear to them that if they really want to get elected, they need to do the right thing. So this is where it is really. I don't think this is going to pass this year. I hope it will, but I'm a little bit skeptical. But it's only going to pass when all of us are making noise to our legislators that this has to change. And we're getting so desperate now. The system is so broken that is actually a possibility.
And with that, it sounds like a perfect entree back to you, Dick.
Yes, and before I turn to the chat, let's talk a little bit more about this California. So the CNA, the Nurses Association, has been in the forefront for several years of trying to get a statewide California program of this kind adopted. If I'm not mistaken, 3 or 4 or 5 years ago, they, I think it was the Assembly that passed it, but then it got into a legislative maze for studying and so forth. It got bogged down when it got to the Senate. Is there, as far as any of you know, a strategy that might overcome the barriers that we know were there 5 years ago, whenever this last effort was made? You have any idea about a new approach or a new strategy with respect to that?
The California Nursing Association, they did introduce a so-called spot bill last year, 1690. It was a simple sentence, basically saying that we plan to create a single universal single payer system, details to follow, which is a year later. And then during that period of time, they've been very actively organizing, identifying, which assembly members need special encouragement, and who could potentially be convinced, which ones they know are going to vote for it, and which ones they know will never vote for it. It's probably not worth wasting your time on them. But they have been organizing. And my understanding is, I think that there are a few more liberal or progressive legislators in the Assembly. It will be introduced into the Assembly first this year than there was before, but it'll be nip and tuck.
Yeah, but let me again go back to how this is ever going to get passed. Some of you may know that this has been going on for a couple of decades at least, and a single payer bill was passed twice in California. Both times were during the administration of a Republican governor who had promised to veto it. That is, the Democrats found a way to vote for it when they knew it wasn't going to go into effect. But every time there's been a Democratic governor who might have signed it, they somehow have come up with objections. And again, I don't want to be too cynical, but I think they didn't want to destroy relationships with people who give them lots of money. So if we really want to do this, we have to get. I think it's not about a strategy in the legislature. I think it's about a strategy in the public. And we need to be on the backs of these legislators. Greg Hart, when we met with him, we started to present something and he immediately said, no, I agree with you. You don't have to teach me about single payer. I'm all on board. Give me the advanced course, not part one. So he clearly said he understands that this is really, really important. But when we asked him, could he support the Calvert bill, he was much more hesitant. He never said he would, and he instead told us a lot of the reasons why it couldn't work. If we want this to work, I don't think it's a matter just of legislative tactics. I think it's a matter of community tactics, public tactics, grassroots organizing. If we organize enough Californians to speak out about this, the message will get heard, and then maybe we have a chance.
So the main political problem at the grassroots, according to people, I'm sure Greg Hart might have said this to you, is that it's perceived as a huge tax increase. And one of the people in the chat raised this. In other words, to create the single payer, this huge tax increase would be put into effect. Of course, all other medical costs of people would be wiped out at the same time. But I think this is in terms of public understanding, maybe the key point to really clear up in terms of grassroots organizing, which is to focus on how do we make people understand that it isn't a tax increase, it's an overall decrease in the costs of living for them.
Perfect, exactly right. That is exactly correct. And I have a friend who says the very first thing that any message about single payer should be, you will pay less. Because that's the truth. But you're exactly right, Dick, that you will pay less, way less out of one pocket and a little more out of another pocket, but the other pocket is called taxes. And that is a big problem. Greg Hart said, tax is a dirty word in California. You need a referendum. And as soon as you put it up to the public, the insurance industry is going to spend millions of dollars saying we're lying. But it is true, it's demonstrably true that this will cost far less and people will pay less. And as most suggested single payer bills are structured, the only people who will pay more at all are billionaires and everybody else will pay less. But it's absolutely, this is a critical notion, is that people have to understand that they will be paying less and probably substantially less and get a lot more. Even traditional Medicare is very flawed in very important ways. It has donut holes where you don't get coverage. There are out-of-pocket expenses are not capped. It can be really, really a problem if you don't have a secondary insurance company, private insurance as currently done. So we need to fix a lot of things, but we could cover all those things with the savings in cost.
Right. Well, some people are happy with their current plan, their current coverage in their current situation. Is there a fear on the part of those people that a new system would actually make things worse for them than it currently is? Is that a political barrier? I'm trying to understand some of the public resistance. We know that the insurance company, the pharma, they don't want to they don't want to lose their hold on the medical market. But at the grassroots, what are the maybe surmountable forms of thinking that people have that might be able to be overcome?
You're absolutely right. That is going to be one of the problems that we face, is that people are going to be afraid of losing what they already have. And what we need to tell them is that, first of all, most people, working age people, are getting their health insurance through their employer. Well, guess what? They could lose their job and then they lose their insurance. And that was perfectly illustrated during the COVID pandemic, when lots of people lost their insurance when they lost their job. So you would no longer have that fear. And the other thing is that, well, several other things. One is that most of the insurance that people have, even though it may be good insurance, there are still a lot of holes in it. There's still deductibles and copays. There's services that may not be covered, et cetera. Hearing, vision, et cetera, is often not included in those plans. And the single payer system would be comprehensive coverage. And then the other thing is that these people who are getting their health insurance through their employer, they really hold on to it because they fought hard to get it through bargaining with their employer. And so that makes them really want to keep what they have. But you also they should realize that once you take healthcare off the table with bargaining with their employer, they're in a better position now to bargain for increased wages and better working conditions. And the other thing is that employers, one of the things that they do to try to break strikes is to threaten to withdraw healthcare from their employees. And so the employees would no longer have this threat hanging over them. So that's be another advantage of a universal system in which healthcare is no longer tied to employment.
So, do you know if any unions who now have control of their members' health care, whether they're now favoring single payer? Has that been a shift?
There are several, yes, that are, not all, but they're moving in that direction. And that's one of the things, for example, that the CalCare, the CNA has been doing, is they've been trying to reach out to labor to bring them on board. Because it's pretty clear that nothing's going to get passed unless you get labor behind it.
I wanted to make a couple of other additions. So just to deal with possible fears that people have. Nancy already said most of it, but I remind people that the single payer system, there would be no pre-authorization and no limited networks. So of course they're going to try to scare people. But the fact is, you would have complete choice. You get to choose who your doctor is. Nobody's going to tell you can't do it. There's no pre-authorization. There's no pre-existing illnesses, etc. Rationing is a dirty word in America, but we ration all the time. But the difference is we now ration according to how much you can pay rather than according to need. And so those are things we need to let people know that you're going to have. This is an expanded system. It's not a limited system. And one other last thing to remind people is that the health insurance is very different than fire insurance. Most traditional insurances are you pay a small amount of money on a regular basis to prevent you from having to pay more than you could if a cataclysm happened. If your house burns down, you can't afford to buy a new house. You can't afford your limited house insurance every year. So that's what you do. We as a community all of us pay a little so that nobody will suffer a tremendous harm. Health insurance is different. And with fire insurance, you hope that you never recover it. You hope that all your money is wasted, that you never had to get your insurance covered. Health insurance is so different because every one of us needs it. And people who are happy with their insurance today, it's mostly because either they have top of the line, they're a senator and they get government insurance, or if you're rich, you can get pretty good insurance. As it is right now, most people are happy with their insurances because they're healthy, because they don't actually need the insurance. Once they get sick and they start needing pre-authorizations and limited ability to go see the doctors they want, Medicare Advantage is a great example of this. You can't go to any experts because most of the university experts are not part of any Medicare Advantage system. Once you get sick, it's really the values of go away.
And just to reiterate, so you're saying under like the currently proposed plan, if you are happy with the doctor that you have, you can go see that doctor.
You can go see any doctor you want.
Okay, so let's turn to some of the chat. By the way, if your hand is up, please try the chat raising a question before, because that's how we want to organize this. So there's a question from Rich Applebaum that contains the following point, that he said people that he knows in England and Canada complain about the system being underfunded, long waits, and so forth. And he's saying if politically the Republican anti-government spending remains the political force, how do we know that the health single-payer system will be adequately funded? Are we headed for crises like now seem to be happening in England with their system? By the way, my impression is everyone in England, most people love and really believe that their health system is one of the crucial things that defines the good life for them. But it's true that there's lots of problems. So what do you think about that?
I think he's right. The fact is we have a federally funded system and there are no funds put into it, that's a catastrophe. England used to spend half what we spend and get much better outcomes. After Brexit, another brilliant idea, after that, their economy is broken, and right-wing politicians always use shock, as Naomi Klein shows in her fabulous book, Shock Doctrine. They always use it to take away our rights. So, of course, after Brexit, the NHS is suffering. Even so, current polls in England show that maybe there are a few people complaining, but it's still the most loved thing in English society. And let's remember as well that far more Americans go to Canada to get healthcare than Canadians come to America. But yes, it's absolutely true that, you know, if we have a terrible government, then we're going to suffer in just about every way.
Okay, well, so there is a suggestion from him and others that when you make these presentations, you should talk about the details of models in other countries, that some that work better than others. For example, Rich gives the example of Denmark, where he found that people pay nothing for their hospitalization, and how is that managed? Then someone else pointed out, but in the Netherlands, people with above median income had to purchase health insurance; those did not pay. What are the different models that probably relevant as we try to figure out what would work best here? You don't have to go into great detail, but is there some general points you can make about that?
Yeah. Do you want me to-
Well, you know, I'm not a health policy expert and I haven't studied the details of other countries, but it is true that there are different versions of how they achieve universal care. But one thing is that once a country has established universal care, people love it and they're ready to defend it.
Yeah, so, you know, I did teach at the School of Public Health for a long time and at UCLA, and all I can say is that I can't really summarize these things very quickly. That we could spend hours talking about different models. They take various forms. There even is a version where
Portion,
I
then.
know.
That's fine, thank you.
Sure.
Yeah,
Karen Adams, would you mute yourself, please?
Sorry.
Yeah, so I'm just going to say, I was just going to say that there is even a model which goes for insurance companies in Switzerland, but there they have tremendously different regulation of insurance industry than we do here. It's not just Switzerland; they're actually a couple.
Germany, this is
Yeah,
that
Germany,
one, but it's
yeah.
highly regulated.
Incredibly regulated in a way that it's almost inconceivable that it would be in the United States. They run from that range all the way over to a true socialized medicine system, like in England. In England, the doctors are on salary. They have an auxiliary system where doctors can practice outside of the NHS, but you can't mix the two. They're very different models. I personally think that the best model is like the British model, but they run a whole gamut of different things. And
then there's also the model of in our own country of the VA, which is a version of socialized medicine. And as Dick mentioned in the beginning, it's now been determined that that is the most efficient version of a healthcare system in the United States because the administrative overhead is lower.
So why isn't the VA system, which applies to millions of people, being foregrounded by advocates for single payer as a model that we're used to already? I mean, if it is that desirable.
good point.
I didn't hear.
Why aren't we showcasing the VA system? And I think, you know, so one of the things is that healthcare doesn't just exist in a vacuum, and it depends upon who's being served and who the patient population is. And as you all know, there are tremendous social problems in a lot of the VA population. And those are the things that the media talks about all the time, rather than what's good about the system. So, you know, there are limits. As you pointed out, Dick, a couple of minutes ago, how the government spends its money and what it provides support for plays a big role on this. So the media often spends a lot of time talking about what is not available to the VA system. For example, in people who are unhoused and have drug problems, etc. Rather than talking about the fact that indeed its overhead is minimal and virtually all the cost goes to providing healthcare.
The other thing about the VA, and I think the reason we would be hesitant to promote it as a model is that the doctors are on salary. And both Jerry and I think, you know, I worked at Kaiser and I was on salary. I loved it. There's no incentive to overtreat or undertreat. It's a great way to be paid, but realistically, in the United States, that's not going to fly. That's just too big a change.
For doctors or
For doctors. It's not going to buy.
Why I'm surprised you said that, because excuse me, somebody interfering with our, sorry, go ahead. I think somebody's, all right, I've lost.
They muted. It's okay now.
Okay. So I'm surprised you said that, Nancy, because isn't Sansom Clinic here? Aren't the doctors on salary there?
I believe they are a salary plus an incentive. I don't know exactly.
And
A productivity.
in other words, my point is it seems to me a larger and larger proportion of doctors do work that way in some form or other.
Yeah, I think that's right. And in addition, a larger and larger proportion of doctors are in favor of single payer. In fact, and that's particularly true of younger doctors, despite the fact that anybody watching the screen will not see that. The American Medical Students Association, which is the student branch of the AMA, is way more progressive than the AMA. And they recently got the AMA to agree. They proposed and passed a resolution that the AMA wouldn't oppose single payer.
So that is now the official AMA policy.
No.
No, that they are not opposed to it.
Yes, no, it's not. They're not supporting it, but they're not going on record as opposing it.
So my entire life, at age 85, we now have achieved that much.
I'm not a big fan of incrementalism.
But, you know, I think it's a very interesting question, is that, you know, whether a survey could be done of doctors and what their opinion is about being salaried. It's very interesting.
But and I think your point is a really good one, which is that if you don't propose something, it never gets discussed and then it never gets advanced. And I'm less pessimistic about what could be achieved if we really went out and said this is a much better way to salary doctors, to pay doctors.
Stanley Froxveg I'm going to call on you, Stanley, because you said veteran system is not that desirable. Would you like to explain what your reservations or your concerns?
Yes, I appreciate the opportunity to respond to that. I happen to be a family physician, old-fashioned. I label myself as a dinosaur because I practiced as most doctors did 45 years ago when I started. And I've worked at the VA hospital. I also have many patients who get VA care. How many of you get your care at the VA? And second question, how many of you have worked at the VA? Do I have any takers?
I've taught at the VA.
Thank you. That's a luxurious position to be in. And so, and you do have some inkling of what it's like, and that's important. I also want to state, before I say anything more, that I'm so incredibly impressed by both of yours presentation. It was some of the most succinct, compelling, and illustrative slides of where we are today. And I had a whole list of things I wanted to refer to, but I'm going to answer the question rather than go off on a digression. And I want to also acknowledge David Lebell is a good friend of mine. So I worked at the VA. It was one of the most inefficient systems, not one of it. It is the most inefficient system I have ever worked in. And I've worked in numerous clinics, private practice, county hospitals, private hospitals, et cetera, et cetera. And to this day, I have never experienced a more inefficient system than the VA. The lengths of stay were not days or a week, they were months. And the care was so haphazard, I could not believe it. Having said that, I still take care of patients who are veterans and get their care, not so much at the VA hospital, or a few of them do go down to LA. I'm in Ventura. Few of them go down to LA and get their care in the hospital. A few of them, we have a nice, very pretty outpatient VA facility now in Ventura. They have a hard time getting anybody to work there as physicians or nurse practitioners, et cetera. I won't go into that aspect, but that's another symptom of the problem. Nevertheless, my patients go there for their basic lab tests because they get in there with continued coverage for their hearing aids, their disabilities that they got through the VA, so they get something, but they do not get any continuity of care there. They prefer to come to my private office. So I just want to clarify that the VA is not the model most people would go to for their care if they had an alternative choice. I'll just leave it at that. Thank you.
Any comment from the panelists? Yeah.
I would love to comment. Yeah, so first of all, you're right. We don't have intimate knowledge of the VA, and so I'm just talking about the larger metrics that we know about. Second of all, as I tried to suggest, I think a lot of you can't take the healthcare provided outside of the social context, and the VA and the VA population has a lot of problems that are different or concentrated in different ways. But in addition, I think this goes back to what you asked about before, Dick, which is who's making the rules in the system. And if doctors in the system, if the VA is not attractive to doctors and nurses, and they don't enforce a system that works well. The VA has a very good medical record system. I don't know if it still does. It used to. It had the best medical record system 20 years ago. But you need to have things like continuity and interactions and communications amongst doctors, et cetera. Those are things that have to be orchestrated. And so if nobody's paying attention to that, because the people who are hired there because they know they're not going to have to do X, Y, and Z. And I don't want to say anything about the providers there because I don't know, but it's certainly possible that without a careful administration, it could all fail. And so I'm not saying there are no problems in the VA. They may be all the ones that you just suggested, or maybe somewhere in between. I don't know. But again, the larger system has to have some of the aspects of the VA model, I think would be great, but it would also need to be run well. And that the devil is, as always, in detail.
The other thing is that, first of all, your experience, first of all, also, I would like to thank you very much for your very generous comments. Thank you. And we would love to have you on board in the fight for single payer. But one has to be careful because it may be that some of the patients who are coming to see you are the ones who are dissatisfied with the VA. Because if you look at the metrics of the outcomes of patients who are being treated at the VA, they're actually very good. They're very good in terms of their outcomes.
Well, I wanted to call on,
let me tell you just an amusing story because we need a little humor in here. I have a friend who was, for a while, she was employed to help with research at the West Side VA in LA. And for some reason, she was looking up the recipe for apple pie. And in the VA, you know how many pages it was? 27. So in terms of efficiency, those kinds of things they can really get bogged down. But they don't have a big, because they're not doing prior authorizations and things like that. They're not figuring out who's eligible for this, that, or the other, to the extent that private insurance is. In that sense, the administrative expenses are.
Well, one of our members here, Jeff Hall, is 100% disabled veteran, and he wants to say something. Jeff?
Sure.
Yes, thank you for the opportunity to speak. I disagree wholeheartedly what I think Stanley said regarding the VA system. I don't know of anyone of my friends or anybody I know in my circle would opt to pay more money for services than needed. I go to the VA. VA provide all of my healthcare needs, my medical needs, my dental needs, and my vision needs. And I don't have to go down to West LA, which we used to have to go to West LA, Los Angeles. I live in Lompoc. We had to catch a bus to go from Lompoc to LA to be treated by the VA. We no longer have to do that. If you live over 25 miles from a VA clinic, you can go to your community. They have a program now that your community healthcare providers can serve you, and the VA will pay the cost of that service. So the system may have a lot of flaws, but it has, I know, a whole bunch of advantages that I think the ordinary public would like. And I think we should look at that system as a model, because I'm 100% satisfied with it. And I have an opportunity to go to Medicare for services. I looked at, I do go to Medicare for services as well. And I looked at a bill that I had from Medicare. It was $200 for, I think, lab tests, and it ended up costing they only got $40 reimbursement versus the $200 that the physician had charged the system. So that's my take on it.
Thank you very much. That was important statement.
That's great. Thank you so much. Again, we don't have intimate experience with the VA, so I don't want to adjudicate this, but I've heard also people complain and other people say it's wonderful. So I do want to again stress that there are elements of the system that are really good, including its medical records, including the fact that as both the administrator and the employer and the physicians, the provider of healthcare, they have the opportunity to control costs way better than anybody else, and which is a really a critical factor. But again, ultimately, it comes down to the details and how is it administered. And I'm sure there are problems, probably different in different VA systems, but there are problems with the administration that can be fixed. The overall model, I think, is a very good one.
So we have a hard rule of breaking, definitely ending at 1:30, but we have a few more minutes if people want to raise additional questions or points. I wanted to suggest one thing in with respect to this fear of a big tax burden kind of fear. Why don't we try to rename what the payment would be by the single payers? In other words, not call it a tax, but call it something else that would make it clear to people that this is the way they are actually paying for all of their medical costs. I mean, it's a premium, not isn't it equivalent to a premium or something like?
Yeah, people have suggested that.
Wonderful. Language really matters, and we've all experienced periods where there are dirty words. Rationing is a dirty word. Death panels, liberal was a dirty word for a long time, and the right uses those fear words all the time. And taxes is another dirty word. It is a dirty word in our society, but if you think about it, it shouldn't be. It's the way that we all contribute so that we can have a commune, that we can take care of the commons. And so, but you're right, we shouldn't call it taxes, we should call it a premium for healthcare, absolutely, and your premiums will go down.
Your overall costs will go down, your premiums will go down, and it's not an increase in your taxes. That's how we need to try to figure out how to frame this. So I mean, I guess the one other question that might be pertinent about the what do you call it, CalCare? What is the name of the bill coming before the legislature? CalCare, is that what it is?
It's CalCare, and the number hasn't been announced.
So
yet.
is it feasible to have a system that works only in one state? Was that an issue?
Well, that is a big issue, because 40% of the money that's spent on healthcare comes from the federal government in California. So you need to get permission from the federal government to fold in that money, such as Medicare dollars, Medicaid dollars, the dollars that are used in the Affordable Care Act to subsidize people's insurance, which, by the way, was an enormous gift to the insurance companies.
Right.
And so you have to get court waivers to allow that to happen. And there's also something else called ERISA, which is a law that says that companies which are self-insured, that you can't mess with their benefits. So that would have to be overcome as well.
So can I just add as well? So we need to do that, and that's part of the process, is to getting a federal waiver. You need to have a bill in order to get the waiver. This is a complicated thing. If we go to hell and get a government that won't ever approve a waiver, or even this government, it's not clear that they would approve the waiver. That's a big obstacle. So this is a real problem, but I wanted to remind people, some of you surely know, that the Canadian system was founded in exactly this way. The Premier of Saskatchewan, Tommy Douglas, a socialist premier of Saskatchewan, that sounds pretty crazy, but he was the one who introduced their Medicare system just in Saskatchewan. And it led to a strike by the doctors of Saskatchewan. And rather than folding because of the strike, they brought in doctors from outside, and it worked so well, and it brought down costs, and people were so happy with it that all the other provinces started their own systems. And just as an anecdote, about 10 years ago, they had a national vote for the most important, the greatest Canadian ever. And they announced the results in a big auditorium in Toronto. And the number two, the second place finish was Wayne Gretzky, but as the greatest Canadian. But number one, they just said Tommy. They didn't say Tommy Douglas. They just said Tommy. And this 2,000 person audience stood up and started howling, clapping deliriously. There's a video of it. So that's how it happened in Canada. It could happen, but it's going to be hard.
So let me suggest a scenario, see if I'm right. That if the legislature, both houses, were to adopt a resolution stating that there is a definite goal with a timetable for establishing a single payer system in California, that the governor signed it because he said he's in favor of universal health care, Governor Newsom. Suppose they did that. It won't create it immediately. They'd have to create a framework, a committee or commission to lead the state in this direction. All of the problems and that you've been raising in getting there would have to be addressed. But at least we would have that kind of agenda in place. Is that the strategy? Rather than, it's not that we're asking Greg Hart to vote for immediately instituting the entire program in one bill. We're asking am I right? We're asking.
Yes.
You are exactly right. And we're sitting here at this table where we're all together with Amber Caldwell, who's one of our colleagues, and she's been making wonderfully helpful suggestions throughout, whispering in our ear. And she pointed out that Governor Newsom, when he was the mayor of San Francisco, implemented Healthy San Francisco, which was essentially a single payer for a single city, which required that it get the monies from elsewhere that it needed in order to support it. So, but you are exactly right that this is, we said that to Greg. Can't you support it just as a concept, that this is a first step that is critical to going further, and he said, no, you can't do anything in California without having all the I's dotted and the T's crossed. And of course, when you get the I's dotted and the T's crossed, that's when the insurance industry is gonna, make up things about all of it. So it's a very difficult political thing. And again, I would just stress my own belief is that it'll only happen if we all get together and make the politicians, even the supportive politicians, know that they have to vote for it.
We're
So-
not 100% sure of where Newsom is coming from. He did say when he was running for governor that he was in support of it,
Yeah.
but I think he's waffled since then.
Well, he's running for president now at some point, and so,
Yeah, I think that's the reason he's
well,
waffled.
we don't know. Sarah, would you like the last word on this program? Sarah McDonald?
Thank you so much for this wonderful panel. I'm a member of the SynCal Health family, and I'm on the board as the recipient board member. And this is not an ad, and this is my own personal thing. I've been a member of SynCal for 7 years. Prior to that, I had to I was forced to spend down assets and go into poverty to get health care. And that's not something one does blithely. And the one thing I want to say is that SynCal, when I switched over to SynCal, I was able to take all my doctors with me, my eye doctor. I even could get dental and all those little things. But I'm also one person that they haven't put a foot wrong. Even the authorizations were not a problem. So SynCal is represented in Santa Barbara and San Luis County, and it makes, and the medications, talk about that. I was able, when I saw the price on Paxlovid, I was a little shocked because I had COVID about a year ago, and I never gave it a thought how much that the drug was, and SynCal covered it. So we've got to work together with all our healthcare plans, and we've got to work together. We've got to solve this problem. And as a member of the Poor People's Campaign, my other hat I wear, poverty is the 4th leading cause of death in the United States. That ain't right. And that's my comments. Thank you.
Well, thank you very much. So I think this is a good opportunity. Any other last minute comments or questions?
Well, I would just say that I think, SynCal working in Santa Barbara is one thing, but down in Los Angeles, where you have the Medi-Cal, so many of the doctors will not accept it. So that's a problem.
No, Medi-Cal is much better than Medicare in terms of the donut holes. It is way better. It's a much more comprehensive system. But as Nancy says, unfortunately, it pays doctors very, very little. And while I tend not to be terribly sympathetic to doctors complaining about money, it is true that many of them would lose money on many of their Medicaid visits. So if you have a centrally funded program, you need to fund it well enough to work. And when it is funded well enough, it's terrific.
And if I could just say one thing, just in terms of logistics, some of the slides that Nancy has made, and there's many more, as someone's mentioned, they're super informative. And if Nancy's willing to share some of them, they should get a hold of SBCAN, and then they can get a hold of Nancy and she can share them.
So I want to thank you, Dr. David, Dr. Jerome, and Dr. Nancy for giving us this enlightening and in a way inspiring, informative panel. I want to thank all of you for being here. to remind you and thank Nancy, our staff member, Nancy Vos. She engineered this from the beginning. She was her idea that we do this, should have acknowledged. And I think she was operating the slides and everything that made this happen so smoothly. So thanks to that, Nancy, for that.
Yeah, yeah, she did a great job.
And so all of you, if you're not a member of SBCAN, now's the time to think about it. And also sign up to get our regular announcements if you don't get those. Thank you all for being here, and hang in there and carry on. Let's go forward if we can with a bit of hope for this coming year.
Thank you, Dick.
Say
Yeah.
goodbye.
Thank you very
Bye-bye.
much.
Thank you, everyone.
Thank you.